Good afternoon, everybody. It is my great pleasure again to be back and have a chance to meet you, or even if it's just a virtual meeting. Today, I'm going to give you an overview of the latest information regarding the beta thalassemia, current and future treatment approaches. And this is my disclaimer. So this is for the scientific purpose only. It's not a promotional or influencing your prescription or the treatment decision. So I want to give you some of the latest information about the update in the field of thalassemia. And I think all of you are clinicians, so you take all this scientific information and make the decision yourself with a discussion with your patient. My name is Professor Viprasit. I'm a pediatric hematologist working at Division of Hematology Oncology, Department Pediatrics, Faculty of Medicine, Sirat Hospital, Mahidol University. And I am also the research director for Thalassemia Center at Mahidol University. So if you like to contact me, you can contact me by the double web or vip.vip@mahidol.ac.th. So, and this is my personal disclosure. I'm consulting for several pharmaceutical companies and also received research funding, including Agios, Celgene, or now it's the BMS, Roche, Novartis, Protagonist Therapeutics, and several others. So let's start with the first part of what I try to let you know today regarding how do we treat beta thalassemia in 2021, which is the integration in the standard of care for patients with beta thalassemia. So in the latest Thalassemia International Federation or TIFF guideline, which just recently launched early this year. So this is the most current standard guidelines for the treatment of transfusion-dependent thalassemia, and it's based on the original guideline, which I be part of the co-authorship back in 2014. So most of the concept in this guideline remain similar to the previous guideline in 2014. However, there are few new recommendations which has recently been added into this new guideline because of the latest information and the latest clinical trial, including the treatment of the new novel therapy in thalassemia. So today we're going to see whether, what do you already know regarding the how do we treat thalassemia patients based on the international standard and what have been recently added. So let's just follow me. So the concept of transfusion dependent and non-transfusion dependent thalassemia has started back in 2008, 2009, and it had been shown in the first guideline in 2012 and later on in 2014 for NTDT and TDT respectively. And I've been part of this movement back then. And in the guideline, which is quite similar to the one that I mentioned earlier, so when you make the diagnosis of patients with beta thalassemia who require regular transfusion to survive, or transfusion-dependent thalassemia or TDT, so first we need to look for eligibility for transplantation, because we know that in TDT patients, they require lifelong blood transfusion. So if they can be transplanted using the stem cell, either matched or unmatched or unrelated donor, okay, that would be best for the patient. So when we make the diagnosis, we monitor, we prevent and management of all the complications. That's very important. We consider eligibility of all possible clinical trial with the new therapies. And also looking for eligibility for transplantation. If they're under 12 years of age, consider hematopoietic stem cell transplantation if they have matched sibling donor. But if they over 12 years of age, we do transplantation if the patient are well chelated. However, if there is no match sibling donor transplantation, you should consider the use of the unrelated donor, or you use the cord blood or haploidentical transplantation. If the patient over 12 years of age, the possibility of the use of gene therapy is possible because it's already been registered using the baby globin genes author stem cell, and that usually indicated for the patient with non-beta 0 beta 0. So after the stem cell transplantation, if it becomes successful, so the patient no longer need regular blood transfusion, so we just monitor them for possibility of the long-term complication which might be related to the iron overload. But if they require transfusion, we still have to continue to monitor them as the TDT. However, if they are not eligible for transplantation or the gene therapy, of course, we have to use the regular blood transfusion in order to keep the target pre-transfusion hemoglobin around 9 to 10.5. And if the patient have the heart disease, we have to keep the pre-transfusion hemoglobin at the level of 11 to 12. After a period of regular blood transfusion, patient will require the monitoring for the iron overload because of the iron overload is a major long-term complication leading to endocrinopathies and several end organ damages in the patient. So we have to monitor with the serum ferritin, MRI for the liver and concentration, and the cardiac T2 star. And start to use the iron chelation therapy in pediatric patients from 2 years of age using deferral or deferoxamine, deferral or the defracyral. And if the patient over 6 years of age, we can use deferriprone. So the choice of the chelation and the doses is depend on several factors, including the iron intake, iron overload profile, and also the presence or the absence of the heart failure and the local prescription information. But the most important is to regularly transfuse and monitor the iron overload regularly by the use of serum ferritin and the MRI. So the new adding information that have been presented in this TIF guideline, if the patient is over 18 years of age, they might consider to use a new erythroid maturation agent or Luspatercept, which now being registered in US and EU, and starting with a dose of 1 milligram per kilogram subcutaneous every 3 weeks. And we do the dose adjustment, monitoring, and managing for the adverse event based on the local prescription information. So in the new TIF guideline, chapter 18, there's several new novel therapy, including correction for the alpha and the beta globin chain imbalance by using the gene therapy, targeting ineffective erythropoiesis, and improve the iron dysregulation. In the second part of my talk, that will follow from the previous slide, which is the rationale for the novel therapy in thalassemia. In order to understand the pathology in thalassemia, you need to understand what really happened in normal erythropoiesis. We divide the normal erythropoiesis into 2 stages. One is the early stage of erythropoiesis, and the second is the terminal erythroid differentiation. In the early stage, we develop erythroid from hematopoietic stem cell to BFUE, CFUE, and ProE. In the terminal erythroid differentiation, we further develop into the early erythroblast, late erythroblast, reticulocytes, and red blood cell. The major difference between these two stages is the production of the hemoglobin, which is a major molecule in the cytosol of the red blood cell. In the early state of erythropoiesis, the cell develops but not much producing the hemoglobin, which is the major function of the red blood cell. But in the terminal erythroid differentiation, you will see that besides the pyknotic of the nucleus, the cell will produce more and more hemoglobin molecule in size, and that affecting the color and make it become more pinky or red in the mature red blood cell. Besides the difference in the hemoglobin production, the process of this early and the late stage of erythropoiesis also under control differently. During the early stage of erythropoiesis, which is around day 10 to 14 days, this is under control of EPO or erythropoietin. However, in the late stage, which is lasts around 3 to 4 days from erythroblast to the red blood cell, this is not under control of the EPO, but is become under control of the iron or iron dependent. Because as I mentioned earlier, our iron also a very important component of the hemoglobin molecule. So in patients with thalassemia, when you have the globin gene mutation leading to an impair of the production of alpha and the beta globin ratio, so you can see that erythroid production can develop in the early stage of erythropoiesis. However, when it goes into the late stage of erythropoiesis, the hemoglobin supposed to produce. However, because of this genetic defect, they cannot produce the normal hemoglobin, which is a hemoglobin trimer. The unpair of the globin chain. For example, in beta thalassemia, you will have free alpha globin, and this leads to the erythroid pathology, especially in effective erythropoiesis, when these unpaired alpha globin chain precipitated in the cytosol of the erythroblast. And further, if these unpaired alpha can further develop into the late stage of erythropoiesis, this alpha hemichrome will precipitate on the membrane of the red blood cell, leading to peripheral red blood cell hemolysis. So as you can see that this pathology usually occur during the terminal erythroid differentiation. The process of ineffective erythropoiesis, if you take the bone marrow from the patient out and look very carefully, you will see that in the bone marrow of the patient with thalassemia, they have a full of young erythroid cells, but not undergone to terminal erythroid differentiation. And this we call the maturation arrest. This leads to the expansion of the early stage of erythropoiesis. Because of this erythroid expansion, the bone of the patient becomes thinner, or osteoporosis or osteopenia. Some part of erythropoiesis occur outside the bone marrow. That's why we observe the extramedullary hematopoietic mass in the patient. Some of these occur in the liver and the spleen. The patient have hepatosplenomegaly. So erythroid maturation arrest is a very important pathology in effective erythropoiesis that we identify in patients with thalassemia. So the process of ineffective erythropoiesis is the middle or the heart of the pathology in patients with thalassemia. Because of this ineffective erythropoiesis leading to chronic anemia, patient require transfusion, and when we give blood to the patient, they have iron overload. Moreover, ineffective erythropoiesis will drive hepcidin ferroportin axis. When you have the IE, it will suppress the hepcidin, And as a result of that, we will have increased expression of ferroportin, leading to the primary iron overload because we absorb more iron through the gastrointestinal tract. So there are three important angles that we can tackle. First, we can make the alpha and the beta globin chain imbalance become more balanced by the use of the gene therapy, genome editing, or use of the hemoglobin F inducing agent such as hydroxyurea. So this kind of reactivating the beta globin chain in case of the beta thalassemia. Another way that we can tackle and will be the focus of my lecture today is the modulating ineffective erythropoiesis. As I mentioned that RE is caused by the erythroid maturation arrest in the early stage of erythropoiesis. So there is a new molecule which can drive and augment the erythroid maturation agent, which is luspatercept. There are also some other molecules, other compounds, such as pyruvate kinase activators or mitapivat, the JAK2 inhibitor, which have been shown earlier in blood several years back, that can help to moderate infective erythropoiesis, or the glycine transport inhibitor or bitopertin. However, these latest two molecules have been shown to not that really effective in the clinical trial, so there are no further development of the JAK2 inhibitor and the glycine transport inhibitor. So we now focus on the erythroid maturation agent and the PK activator. Last but not least, as I mentioned, that the iron also very important for the terminal erythroid differentiation is control this late state of erythropoiesis. So we know that in the patient with thalassemia, there is a low level of hepcidin. So if we can reduce this iron-restricted erythropoiesis, we can improve erythropoiesis in the patient. So there are several molecules that are underdeveloped, including our hepcidin mimic molecule, the stimulation of the hepcidin product, and the ferroportin inhibitor. So today we're going to focus on how do we modulating ineffective erythropoiesis. The process of ineffective erythropoiesis is linked with the dysregulation of the TGF-beta and the SMAD pathway. Normally, the TGF or transforming growth factor beta superfamily is signaled and has action on the cell crescents, the apoptosis, erythroid proliferation, differentiation, migration, and control hematopoiesis. So the molecule of the activin A, B, C, and E, or within the GDF family, will interact with the activin receptor. And this activin receptor, when it shifts to bind with the GDF11, it will leading to a phosphorylation of the SMAD molecule. And this SMAD molecule will go to the nucleus and drive several genes that related to the ineffective erythropoiesis. So in ineffective erythropoiesis, both in MDS and thalassemia, we know that there is an increase of molecules such as the GDF11, and that lead to the ligand and receptor binding of the TGF-beta superfamily, that leading to the hyperstimulation of the SMAD2/3 pathway, that's called a phosphorylation, and this elevation of the SMAD ligand level leading to the impair of erythroid maturation. So, and this is the a major pathology that underlie patient with thalassemia, and this is what we have been shown through several basic studies in the thalassemic stem cell. So if we can remove this hyperstimulation of the SMAD signaling pathway, we shall be able to release these maturation arrest, as I showed in the previous slide. So how can we remove this hyperactivation? Of course, we need to trap all these ligand of the activin ligand. So we have these chimeric antibodies which has been generated. They have the modified extracellular domain of the activin 2B and have the human IgG1 or Fc domain. And these antibody will trap the ligand of the TGF-beta and SMAD pathway, leading to the reduction of the SMAD signaling pathway. So we can release the pores of erythroid maturation. So we call this agent as the erythroid maturation agent. So what is the current clinical data on the erythroid maturation agent? So the Luspatercept and Sotatercept are two prototypes of the erythroid maturating agents. So for the Sotatercept or ACE536 has been analyzed in the two phase 2 study in patients with both TDT and NTDT, and they have the key measurement for the TDT for the transfusion reduction, at least over 20%, and for the NTDT, increase the hemoglobin production over or equal to 1.5 gram per deciliter. For the Sotatercept, it's also another molecule of the chimeric antibodies. So it had been analyzed in the phase 2 clinical trial as well in TDT and NTDT and has the similar kind of the key efficacy measure. However, due to the possibility of the endocrine complication in Sotatercept, so this molecule has not been further developed for the patient with thalassemia. So now we focus only on the Luspatercept. So besides the phase 2 study, we have another important registration study called the BELIEF trial, which I'm going to review with you about the key information about this study today. And also the latest information on the NTDT trial, which is we call the BEYOND trial. However, due to the registration regulation, I'm not going to discuss about the BEYOND trial today. I hope that maybe in maybe next year I can share you with the data on the BEYOND study. And finally, I am leading another clinical trial in pediatric population, and this trial is under execution in Thailand at present. So in the phase 2 trial, as I mentioned earlier on Luspatercept, that we study the effect of this erythroid maturation agent in 64 adults, both TDT and NTDT. They all have the beta thalassemia. The patient received the dose adjusting starting from 0.2 to 1.25 milligram every 3 weeks. And because this is a dose finding study, so we start with a very low dose. So later on from this study, we know that the starting dose has to be 1 milligram. In this study of the phase 2, we have the extension to continue the study drug up to 5 years. For TDT patient, we're looking for the clinical response that the patient can reduce transfusion over 20% from the baseline. And for the NTDT, they can increase the baseline hemoglobin around 1.5 gram per deciliter. And based on the phase 2 trial, which is published in Blood back in 2019, the Luspatercept can achieve the primary endpoint for both population of TDT and NTDT. And in this picture, show you one of the NTDT patients who have a chronic leg ulcer. So you can see a remarkable improvement in terms of the wound healing in patients with NTDT, meaning that the increment of the hemoglobin has a functional effect in terms of the peripheral tissue oxygenation as well. For the BELIEVE trial, this is a randomized, double-blind, placebo-controlled phase 3 study of luspatercept in adult patients with TDT. So the inclusion criteria is the patient has to be over 18, receive regular blood transfusion, at least 6 to 20 red blood cell units within 24 weeks prior to the randomization, and has no transfusion-free period over 35 days. So we include around 336 patients, and this is the randomized in 2:1 ratio. So around 224 patients will receive luspatercept, starting with 1 milligram every 21 days, and another arm will receive placebo, and after 48 weeks, which is a blinding period, we unblind and we continue the study. In the patient who receive placebo, they can switch into the luspatercept arm, and we still on the ongoing follow-up this patient for 5 years. The primary data of this BELIEVE trial have been published in New England Journal of Medicine in 2020, and this is the primary endpoint of the study. We want to look at the percentage of the patient who can achieve the overall transfusion burden reduction over 33%. And you can see that in luspatercept arm has the proportion of the patient up to 21.4% compared to only 4.5% in placebo arm. So this is has a statistical significance. So it's achieved the primary endpoint. Also, when we look at the subgroup analysis of the patient who received luspatercept compared to placebo in the different demographic data, for example, the region of living, the age of the patient, the history of splenectomy or not, the difference of gender, the type of thalassemia, both beta 0, beta 0, or non beta 0, beta 0, the baseline hemoglobin, the baseline iron status. So you can see that across different characteristics, the luspatercept still achieves the primary endpoint by a significant reduction of transfusion requirement over 33%. Also, the other key secondary endpoint has been met by luspatercept. As you can see on this slide, at the orange bar represents luspatercept and the blue bar is the placebo. So the proportion of the patient that we can achieve transfusion reduction over 33% from week 37 to week 48 is significant or higher in luspatercept. And if we're looking at in the group that have the even more reduction over 50% from the baseline at either 13 week to 24 or 37 to 48 week, you can see that luspatercept also achieve a clinical meaningful reduction in transfusion burden compared to the placebo. Besides the proportion of transfusion reduction, we also looking at the reduction in the red blood cell transfusion burden during any 12-week and 24-week interval. Again, luspatercept show a significant reduction at any 12-week interval and 24-week interval compared to the placebo. So significantly more patients treated with luspatercept versus the placebo achieved reduction in red blood cell transfusion burden of over 33% and over 50% during any 12-week or 24-week interval. In terms of the safety profile, the luspatercept has a very good safety summary. As you can see on this slide, the number of the patients who have the treatment emerging adverse event not significantly different between the luspatercept and the placebo. And one of the major adverse events that have been reported is the bone pain and arthralgia, which seem to be much more present in luspatercept arm. Based on our experience, we have treated over 60 patients in BELIEVE trial. This, for me, is a good signal of the clinical response in patients with luspatercept. And most of the bone pain or arthralgia usually disappear or after the third or the fourth dose of the treatment. Besides the reduction in terms of the blood transfusion, as you can guess that because patients receive less blood transfusion, luspatercept should have the effect in terms of the reduction of the iron overload and might reduce the need for the iron chelation therapy. So in the BELIEVE trial, we have a chance to looking and analyze the iron status in the patient. So we can, as you can see that there is a higher proportion of luspatercept treated patients shift to the lower serum ferritin, LIC, and myocardial iron level during the first 48 weeks of the treatment, indicating the lower risk of the iron overload complication. And also, when we're looking at a more long-term follow-up at the week 96, you can see that the patient with the luspatercept arm has increased patient percentage to have the LIC lowering in the lower range, and also the myocardial T2 stop. So this is a longitudinal effect of the use of luspatercept in terms of the improving the iron overload status in patients with beta thalassemia. So what is the current recommendation? And I'm going to summarize regarding the novel therapies. So the luspatercept have been approved from the US FDA in 2019 and by the EMA in 2020 to treat anemia in adult patients with beta thalassemia who require regular red blood cell transfusion. And this year, TIF has already included luspatercept as a novel therapy to be considered for transfusion-dependent thalassemia patients. So in the latest TIF guideline, they summarize that the luspatercept, or as the commercial name as Reblozyl, has been authorized by EMA and FDA, has seemed to be quite promising, with significant improvement in the hemoglobin level and reduction in transfusion requirement. Moreover, this reduction in transfusion burden decreases ongoing iron intake, and thus the iron chelation therapy requirement can be reduced. So the reduction in the serum ferritin level observed with the luspatercept arms also suggests several early effects on the iron balance. So this effect may be due to the improved iron utilization because we reduce ineffective erythropoiesis in the thalassemic stem cell, and we are also promoting the new and novel of the red cell production. We can also reduce transfusion requirement in the patient, so that while we reduce the iron intake and also improve the efficacy of the iron chelation therapy. So in patients who have a limitation to access to blood transfusion, so the use of luspatercept can be a very good option to help reduce transfusion requirement. And also the ongoing study in the NTDT also show a very promising result, and it might have a further indication to be used in the NTDT patient as well. So in summary, I talked to you today regarding the novel therapy for thalassemia, including the rebalancing the globin synthesis, modulating ineffective erythropoiesis, and reducing the iron-restricted erythropoiesis. At present, only targeting ineffective erythropoiesis has a new indication and recommendation for the treatment of the patient, and this provides a new target for thalassemia therapy. So the activin ligand trapper, such as luspatercept, which is acting on the TGF-beta and SMAD pathway, is the first of its class of modulating erythropoietic drug. So it has roles on TDT patient and possible role in NTDT. The result from the ongoing and the presented clinical study suggests a role of luspatercept as recommended specific treatment for beta thalassemia patients. So for many years that we treat patients with beta thalassemia with the supportive therapy, blood transfusion, iron chelation therapy, and this is the first time in the history of thalassemia that we have a targeted therapy or specific therapy for patients with thalassemia. So we directly target ineffective erythropoiesis of the patient. And this novel therapy has been shown to be effective with a very good tolerability. The safety profile is no concern. So, of course, when the new therapy coming into the country, for example, like in my country, so we need a support from the pharmaceutical company, from the patient support group, and also, of course, the patient who need to understand the latest scientific development for them. And most important pillar is all clinicians like yourself. So we have to work together. In Thailand now, we are in collaborating with all the stakeholders to make all new novel therapy become available for our patients. So Luspatercept will have registration in Thailand early next year. And I have heard that it's probably going to be the same for Malaysia as well. So as they said, together we stronger. So our collaboration, our help, our work together with all the stakeholders will make this all novel therapy become possible to improve the care of our patient. Thank you very much for your attention. And if you have any question, I will be very happy to answer. And later on, if you can think of about some other things, you can email me or you can line me. Thank you very much.